A very good morning, doctors. So it has been a very good sessions through these 6 months. A very good morning. I hope I'm audible. So if I'm not audible, please let me know in the chat box so that I can do, if it is required, I can do any changes. So it has been a very good session. For the past 6 months, we have been conducting this free webinars and we have been welcomed by all. Actually, for my first webinar, to be frank, for my first webinar was attended by my very close friends only, like around 20 to 30 people. And then slowly it started growing. And now, in actual, I am getting DMs from many people that they are not able to register for it because we have crossed the registrations yesterday itself. So I have had 100 registration completely filled, and many people are actually DMing me. So I have decided that I will be putting this video, today's webinar, live in YouTube because I want maximum people to get use from this. So, like, if your friends are not able to log in or not able to register, tell them don't, no need to worry, because I will be sharing this webinar on YouTube as well. So you can revise also. So this topic was actually a very confusing one for me because this topic was actually very confusing for me as well. When I was doing my PG, I did not want to go into this Rotary Files because this art and sick, mart and citic, this R phase, everything, it confuses me a lot. So I was like someone who was very reluctant about files. And I usually, to be frank, I was not going into the files. I used to always study about, deep caries management, biodentin, MTA. That is my actually, niche, and composite restoration. That is actually my favorite part, because of which I used to focus only on that. Even my thesis were related to it. Even my everything was related to it. Even after I finished also, I used to not worry that much about Rotary until and then, like when I started to practice. So there were questions in my mind arising that what type of file am I buying? Because I get approached by many representatives taking up files and coming to me, ma'am, use this, ma'am, use that, and they will give me free, even they give me some free files also, so that I can use and I can promote them. But I started getting questions in my mind, am I using the right file? So that is like around 4 or 3 years back, I started getting those questions like, am I using the right file? So I was like, I used to just use a single file. I used to buy only the ProTaper Gold dense ply, or I used to buy a high flex EDM, and I used to use that. I used to never think about whether what I'm using is right or not. I used to think I'm buying a file which is of high cost, so it should be good. So that was my general notion that, okay, I am buying a file which is of high price, so maybe it is good. So that is why I'm buying. So that was my general notion. After that, I started questioning. So I was like, I did some research on what type of files are there, why there are so many colors, and how does it influence. So recently, like I came across something like 6 months or 8 months back, I came across something that your files can actually affect your post-obturation pain. So I did have an idea that files will influence, but I did not know that this much influence they will have. And that is very important while selecting a file when we are going to do a case. So that is why I wanted to share the information or research I have done. And also, I did not go on straight with this topic to the webinar. Actually, I bought different files. I used it myself in the 6 or 8 months. I have been using many types of files. So if someone who has attended my, my course, comprehensive endo, I would be showing them all the files I'm having. Literally, I don't keep in track how many files I have been using now. I have stopped using a single type of file because I wanted to teach. So I wanted to explore. So I started using many types of files and see which is good, which is not good, and I started exploring. So now I'm a little bit clear. I think I'm clear, because the learning never stops. But I wanted to share what I have come in conclusion to. So whenever you're going to have a patient, usually when you're going to do a RCT, after obturation, if the patient is having pain, so mostly there will be two types of pain. So one will be when the patient is biting. Okay, only when the patient is biting. And what we do, we will reduce occlusal reduction, we will do, and we will think, okay, this will actually heal the patient. But in actual, even while biting, the patient shouldn't have pain. That is a very much successful RCT. Okay, when an RCT is done 100% correctly, okay, without any human errors and without any errors, and all the protocol was followed correctly, then the patient shouldn't have pain even when the patient is biting. In fact, we should not require occlusal reduction. So there is a common notion that every RC treated teeth should be restored with a crown, but that itself is not a principle. So only when it is required, you need to restore it with crown. So now if you're going to do occlusal reduction for every RC treated tooth, you will not be able to explore any other conservative options like inlay or onlay, even a composite restoration for a RC treated tooth, because you have already reduced the occlusion. So you need to go for a crown. So that is why it is always better you do the RCT correctly, so that the patient is not having any post-obturation pain or having very minimum pain. So very minimum pain, that is like even though you're going to do everything correctly, there will be some errors which are like unknown to us, because of which you can have pain like post-obturation pain for 1 or 2 days after obturation, only mild pain when the patient is biting, which is considered okay, near to normal. Now, coming to continuous pain for 1 week or 2 weeks while the patient is biting, or the patient is having continuous pain, like on the same day of obturation, you're obturating today, and today night the patient is going to have a immense pain. So if you have heard from your patient, the next day when you're going to call them for a review call, the patient will be telling, yesterday I had a lot of pain, I took medication, it was okay. Now, right now, the pain is tapering. Actually, in fact, even though the pain is tapering, it is an alarm, because if the patient is having immense pain just after you obturating on the same day, that is also a red flag. So, I will tell you how to reduce that pain, how to completely make the procedure painless. Because, nowadays, I don't know, but I have a general notion. I don't focus on the, like, what to say, patient, when the patient comes in pain, I focus on giving the patient a painless treatment. I believe that more than the infrastructure of the clinic, or more than what we are giving, how much we are charging, what type of material we are doing, what type of treatment we are doing, the patient will actually worry only about the pain. Okay, so if the procedure was painless and comfortable, the patient is going to give you a 5-star rating. So that is what I believe in. So you have to make the procedure as painless as possible, so that you can give the you can get the maximum rating from your patient, because it is all Google rating only nowadays. So I'm talking in that language. So how you can give them a very good painless root canal treatment. So coming to the first mistake which we do is the wrong working length. So this is not related to the topic, but I wanted to cover the common post-obturation pain reasons first, and then come to the rotary files, how it influences. So starting with the working length. So wrong working length is when you're going to depend only on your radiograph, only on your RVG. Sometimes you tend to do this mistake. So now when you're going to take an X-ray, what is visible in your X-ray as a apex is this radiographic apex. Okay. So now coming to the actual analysis. So you need to stop your BMP at this area, at the minor constriction. Okay, so at the minor constriction itself, only when you're going to stop your working length or stop your BMP or stop your obturation at this minor constriction level, you will achieve something called a hermetic seal. And also in the periapical region, you will have some periodontal fibers connecting. So these periodontal fibers, when left unaffected, the patient is not going to have any pain while biting. So this is the major reason why the patient is having pain even after obturation. for 1 to 2 weeks, because sometimes you might have crossed that minor constriction and gone into this region, the spinal region, that is the apical foramen. So this apical foramen will also have some amounts of periodontal ligament fibers. Those periodontal ligament fibers, we won't remove it. In fact, we will injure it when we are going to instrument it. So what will happen? The patient is going to have an inflammation, and the patient will have pain whenever they are biting. So it is always necessary that you keep 1 mm shorter than the radiographical apex. If you're going to take only if you're going to depend only on your radiograph, it is always better to keep 1 mm less than your radiographical apex, not zero point 0.5 mm. I never recommend 0.5 mm. I recommend only 1 mm, because even though we are going to measure it correctly, so the first root canal will be somewhat not a very uniform. As we keep on preparing, it is going to become like a straight road. So when you're going to travel in a curved road, your path looks very far away, right? The same way, as you keep on filing the canal, it becomes straight, and also that will also change the distance. So that will also change the working length. So it is always safer. You need to keep your apex, your working length 1 mm shorter, not zero point 0.5 mm shorter. So when you're going to take the X-ray, your GP will be like at the apex. Okay, so you will think, I have done a good RCT, then why the patient is having pain? The patient's pain is because of this reason. That is not at the apex, is not the ideal one. You have to keep it 1 mm shorter than the apex. That will be the ideal one. And even if there is a little bit of, you're shorter than the minor constriction, also the sealer will flow there, and you will get a proper, seal will be there, and the patient is not going to have any pain. So this can be prevented if you are not like depending completely on radiograph. You can always go in for this as well, apex locator. So when you're going to combine apex locator as well for working length, then you will have a accurate reading. So what you can do, you can measure the working length first with apex locator, then you can check it whether it is correct in a radiograph. So at the apex is not the ideal one. You have to keep it 1 mm shorter than the apex. And next will be the pain. When it is very continuous and very severe, we have to consider missed anatomy. So whenever the patient is going to have night pain, okay, so the patient tells you that after obturation, the patient had severe pain at night, and the pain actually increases at night, and the pain actually comes back at night. So these type of signs indicate that whenever there is a night pain, you can understand that there is a pulp tissue. Because when the pulp tissue is getting inflamed, when the patient is going to lie down, the blood supply to the pulp tissue is more, and the patient is going to get a night pain. So when there will be pulp tissue remnants inside the canal, when we are going to miss a canal or a miss an anatomy without proper BMP. So this will be the major reason. This you can, like whenever the patient is going to have continuous pain or night pain, you can consider missed anatomy. And the only way to recover or to correct it will be to do repeated RCT. You can leave the canals which you have completely cleaned and obturated. They need not be disturbed at all. So you can try to find the missed canal, and if you think that you will not be able to find, you can always take a CBCT and confirm whether you have missed any canal, and then you can reopen it. So when you're going to reopen, if you want to check whether pulp tissue remnants are there, you can always go in for a conventional technique. Okay, very conventional technique. This is in a champagne bubble test. So when you're going to put a sodium hypo on the pulp chamber, there will be bubbles. The bubbles will be present only in the presence of pulp tissue. So if there is no pulp tissue, no bubbles. So that way you can understand that the pain is because of pulp tissue, not because of any other reasons. So if you know that missed canal is the problem, you can always take a CBCT, or you can try to find the missed canal where it will be, and you can recover it. So this will be another reason why the patient has post-obturation pain. And then will be the reason, very common reason is when the patient, when you are not following the proper disinfection protocol, that is the proper irrigants protocol and proper intracanal medicament protocol. So general, I'm going to give you a, take home irrigation protocol which I have been following, and I have been, you know which is actually the protocol done in many studies, and they have come to a conclusion. So first will be your sodium hypo. So I believe there are two parts in our canal. One will be your organic part, and another one will be your inorganic part. So your organic part is nothing but your pulp, and your inorganic part is nothing but your canal walls. So your organic part needs to be removed with a sodium hypo. So the only agent which can dissolute a pulp, your pulp tissues and your the bacterias, and the devitalizing agent, the only thing will be a sodium hypo. So you start with sodium hypo in vital tooth, and you remove the pulp, you extirpate the pulp, and then you follow it with EDTA. So EDTA is the agent which is going to remove the inorganic part of the your canal. So there are some bacteria like your E. faecalis, which is the major reason for your RCT failure. So those E. faecalis, they are going to penetrate deep into the dentinal tubules, nearly 1 mm into the dentinal tubules. So there is a general belief that when you're going to remove the smear layer from the dentinal tubules, or when you're going to dissolute, I mean demineralize a little bit of the dentinal tubule walls, only then your sealer will penetrate deeply into the dentinal tubules. And to do that, your EDTA is going to help. This EDTA will help your sealer penetration, thereby giving a proper seal so that you will not have any reinfection. So during RCT, during rotary preparation, you can use EDTA gels for as a lubricant as well, and then you can follow it up after the completing the BMP. Like after each files, you need to wipe off the files and also do saline irrigation, and then repeat, go to the next file. So you should never forget your saline irrigation and to wipe your files before going to the next file size. So it is always very important, because that is where your debris is going to build. Okay. So then finally, after your BMP, you can always give a wash with EDTA liquid. This will actually completely remove the smear layer, and your sealer penetration is going to be 100 percentage when you're going to do this step. And then you can follow it up with chlorhexidine just before obturation. So now chlorhexidine is the only agent which is effective against E. faecalis. So you should not forget this. And E. faecalis problem is not an immediate one, like how I'm telling you. So this post-obturation pain is actually an immediate one, like immediate pain after obturation. But this E. faecalis pain is going to come after 2 to 3 years when the patient is going to have a RCT failure. So you can prevent that too. When you're going to add this chlorhexidine to your regimen, to your irrigants regimen, you're going to reduce the E. faecalis, and the chances of RCT failure is going to reduce to a much extent. The RCT, I can give a guarantee, if you have included chlorhexidine in your preparation, in your irrigation, I can give you a guarantee that the patient will not never have RCT failure, provided there is a proper seal of crown and your obturation material. The patient will never have pain for minimum 10 years. So this is a general protocol which you need to follow. And if you have not included any of these, then the patient might have any pain. And your intracanal medicament. So when you need to differentiate between the cases which you can do it in single appointment and which you cannot do it in single appointment. So there are cases with huge lesions, pus discharge, and sinus openings. Those are not the type of cases which you can do in single appointment. So when you're going to do it in single appointment, there is going to be flare up and there is going to be pain. So those type of cases require intracanal medicament. So you need to differentiate between those cases, and you need not you need not hasten up those type of cases, completing it fast in single appointments, then end up again removing the GP and doing re-RCT. So you have to know the difference, when to close it on one day, when to not close it. And the final one, now we have reached our topic. So the another fourth reason why the patient is going to have post-obturation pain is the apical debris extrusion. So whenever you're going to do a biomechanical preparation, you're going to remove the dentin in the wall. So those dentin and also your debris, your pulp tissue, your bacteria, everything is going to go towards the apical region when you're going to do a rotary filing. So rotary filing or your hand filing. So whenever you're going to do a BMP, your smear layer will be pushed towards the apical region. So this debris will go to the apical region and it will cause some inflammation. So because of which the patient is going to have pain. Now the topic is which type of file is going to reduce apical debris extrusion and which types of file will increase your debris extrusion. Now coming to what happens. So whenever there is going to be, when the file is going to push your debris into the apical region, acute inflammatory response in the periapical tissue are triggered, and that will cause the release of some enzymes like prostaglandins, your, anti-allergy enzymes like histamine, cytokines. So these enzymes are going to cause, inflammation or vasodilation in the periapical region. So they will create a huge pressure. So imagine there is going to be someone hit you on your hand, okay, or you just got pricked in your hand. Suddenly there will be the same type of chemical mediators will come in that region, and it will cause a vasodilation and it will cause a swelling. Okay, so now there is only air in your hand, around your hand. So no problem at all, no pressure. There is going to be a swelling. It will go on. The swelling will reduce in 1 or 2 weeks, and you're not going to feel that much pain. But when it comes to your periapical region, there is going to be bone around. On top you have the tooth, and there is no way to release that pressure, so because of which the patient is going to have immense pain. So this pain is actually the tenderness on biting pain, or the night pain, or the immediate pain on the same day at night. So this will be the major reason. So more the debris, more will be the pain. So more the debris, more will be the chemical mediators, more will be the pressure, and more will be the pain. So our goal is to reduce the debris. So we need to select a file which will reduce the apical extrusion of the debris. So now, for that, you need to understand two principles. I'm not much into physics actually. I didn't like physics, that's why I took dentistry. But then also, sometimes we need to go into physics to understand these, materials and all. So you need to understand two principles. One will be the piston and the auger. So piston is nothing but it is your file is just going to push your debris in the apical region. Okay, auger is something like a spiral. Okay, so what happens when your auger type of file is entering into your canal? It will actually, your debris will come above. Okay, so when this screw type of your files, or your any screws or anything auger type of screws are entering into a wall or entering into a sand, the sand or the debris or the wall debris will come above. Okay, so this principle is what you need to understand when we are going to understand this rotary files. So the piston type, it doesn't have any exit pathway for the debris. So if you can see, when this piston type, it is going to enter the a canal or enter a wall, your debris will be pushed down. Okay, while in auger type, your debris will be pushed above. So, but the problem is when the auger is more, the strength of the file is less. So, if you can see, the spiral is very thin, right? So, your strength will get reduced. But at the same time, we need a auger, but we need the strength of the piston. Okay, so we need the strength of the piston to enter the canal for the centering ability, everything. But at the same time, we need some mechanism of auger so that we can push the debris above without pushing the debris in the apical region. So our file system should be something which is balancing between both the principles. So how to balance? So whenever the flute, so there will be two parts in general. So there are many parts in our rotary files. So I want to focus on two parts. So one will be your core. So file core, and then your flutes. Okay, so this is your flutes and this will be your file core. So this file core and these flutes play a very important role in balancing between your piston and your auger nature of the file. So now whenever there is going to be more distance between the flute, so this will be the space through which your debris is going to come above. Okay, so when you're going to cut through, the debris will raise above through this space. So whenever there is going to be more space in between the flutes, more debris will be going up towards the coronal region. So this is the basic principle. But at the same time, when there is more space in between the flutes, there are chances of reducing the strength of the files, and there might be chances of fracture of the file. So there should be a balance between this flute space and also the file core, so that there is strength as well as there is coronal movement of the debris. So now coming to this is like larger the flute space relative to the core, the better is the file ability to auger debris coronally, reducing the apical extrusion. So this is what I was telling. So now coming to the shapes. So there are four types of cross sections in every file. So I will be telling you some brand names, but I recommend that you verify your files on yourself. Like when you're going to buy, you need to check what cross section as well from today. So starting with your square or rectangular cross sections. So these files are the more, the flute sizes are very less. In between the flutes, the space is very less, and actually it is more rigorous. That is, the cutting edges are very sharp, so it will cut very much. The tooth is cut more, and the debris production is also more, and it will push the debris towards the apical region. Okay, so this is actually a conventional rectangular, a conventional square cross section. So if you can see, this is a conventional one, so sharp edges. You need to know the difference between offset rectangular. So I will come with offset rectangular, so don't get confused between offset rectangular and a conventional rectangular. So conventional rectangular will be a straightforward 90 degrees. Okay, straightforward 90 degrees, all the corners equally placed, touching the canal wall. So the cutting efficiency will be high, but at the same time, pushing of the debris towards the apical region is also very high in your rectangular and square cross sections. Now coming to your second one. So triangular and modified triangular cross section. So triangular and modified triangular cross section will have a good cutting efficiency, but at the same time, there are gaps in between the flutes. Okay, so through these gaps, your debris is going to go out. Okay, to go out towards your coronal region. It will not be pushed in the apical region. So you will have a moderate to low extrusion of debris in your triangular, and there is another one type in this triangular. So when you're comparing your rectangular and square with triangular, your triangle will have much less debris extrusion because there are more gaps. But at the same time, there are two types of triangular. That will be your sharp triangular, and another one will be your a little bit curved one. Okay, so this is actually a modified triangular cross section, and this is a normal conventional triangular cross section. So your normal, when you compare these two triangular cross sections, this modified triangular cross section is going to have less cutting efficiency, and it will have less debris extrusion. Okay, so this is good because it is going to extrude less debris, but at the same time, it is a little bit has a less cutting efficiency. Okay, but your sharp triangular is going to have high cutting efficiency, but it will extrude more debris when compared to this modified triangular. Okay, so when you compare the pain, more pain will be here and less pain here. But relative to your rectangular and triangle, both these are better only. So coming to the types of the files which are available in the market, and you're available in the market is the triangular cross section and your modified triangular cross section. So there are many files. You can take a screenshot of this, but I'm not I'm not promoting Colteen. I'm not promoting Colteen. Okay. But I just wanted to tell because, many people think that I am in collaboration with Colteen. I always promote Colteen, but that is not the thing in actual. So, but I wanted to tell something about Colteen here. This Genendo files, actually the Genendo shaper files, that is the initial files like the S1, S2, they have triangular cross section. So what I told you in previous one, that it is like the sharp edges, right? They have more cutting efficiency and more debris extrusion as well. But at the same time, they have more cutting efficiency. While the modified triangle, they have low cutting efficiency. So in your Genendo files, what they have done, the shaping files, that is the S1, S2, they have been kept as cutting like sharp triangular one, so that they have more cutting efficiency. And as the file size progresses to finishing files, the finishing files are kept as rounded, that is modified triangular one, so that the cutting efficiency will be less and the apical extrusion of the this debris will be less as well. So now why this is important? Because when you're going to do a preparation, when you're going to start doing the preparation, your cutting efficiency should also be good, because if your cutting efficiency is not good, your file will get stuck inside the canal, and your torque, you need more torque, and it will lead to file breakage. So that is why this modification has been done in this Genendo files, so that your initial files have more cutting efficiency and your afterward files will have less cutting efficiency, but at the same time your debris extrusion is very much reduced. So when you're going to use this file, your debris extrusion is going to get balanced, and it is going to be even without compromising the cutting efficiency. And even your vortex blue as well. So your vortex blue, your dense ply, that is the second file which I would recommend. The centering ability of the file is very good, that is it stays in the center of the canal. And also your debris extrusion is very minimum in vortex blue as well, so there is more space. It is also a modified triangular cross section file. So your but the cutting efficiency is relatively low. So what you can do, you need not use it for many cases. Okay, so you can reduce the number of cases so that you can keep the cutting efficiency to the max when you're going to do. It will be maximum when you're going to do the initial cases, it will wear out faster. So that is the only disadvantage. Other than that, there are economical brands as well. So your Genendo is also comes under economical brand only. It is around 1600 to 1800 per pack. And your Neo and Flex files are also triangular cross section only. It is also a modified triangular cross section. It is around 1000, I guess. So there are economical options and there are costlier options as well. It always depends on how much your patient is going to pay you. So I am someone who decides my files based on how much the patient is paying, not based on what is good sometimes. So because it is practical, no, ultimately we have to have a life. So you can choose according to the budget. And then will be your S shape. So the series, your rectangular and square is going to push debris more into the apical region, then followed by your triangle and modified triangle, and then your S and double helix cross section. So this S shape and double helix cross section is going to give more space at the sides, and it will actually push, literally it will push the debris towards the coronal region. It will actually act like a conveyor belt, so it keeps on, when the file is going inside the canal, it will actually conveyor, it will act like a conveyor, and it will push the debris, it will actually push the debris towards the coronal. Literally it is going to push, not only giving the space, it will actually push the debris. So it is much more effective than your triangle. So your triangular, it is going to give some space through which the debris can come above. But your S shape is going to actually actively push the debris towards the coronal region. So this is much more effective. So your literally your post-obturation pain is going to drastically reduce when you're going to use a S shape. And there are two types, okay, S shape and a double helix. So now the cross section will be same, but based on the flute distances, in between the distance between the flutes, it changes whether it is S shape or double helix. So S shape is going to have more inter more distance between your flutes, and your double helix will have less distance, so that it will look like a double helix shape rather than a S shape. So your S shape files will have more distance in between the flutes, so more debris removal towards the coronal region. And your double helix design, it will be in a shape in cross section, but the inter distance between the flutes, right, it will be less compared to your ideal S shape. So this less distance will actually comparatively less removal of debris. So more effective will be your S shape cross section, where you will have more distance in between the flutes. And these are the files which are having this S-shape designs, general files. So I recommend M2, and also I have used Neo Endo S also, so it is very good. You can use that. Or one problem about reciproc. So why I'm not telling reciproc, I will come in the next slide why I'm not telling reciproc. But reciproc is a very good file. It is a single file system. You need not go for multiple, having multiple files, maintaining multiple files. You need not worry about that. Reciproc is a single file system. You choose a single file, prepare, obturate, everything. The time is very much less. But one thing is the reciproc motion. Okay, so this reciproc motion, I will come why I do not recommend reciproc. The file design is good, but the reciproc motion sometimes, accumulates debris. So that is the reason I don't recommend. But yes, you can use it, but with copious irrigation. So you need to, if you're going to choose a reciproc glue, you need to take up a few precautions according to it. You know the file, you know the nature of the file, you need to act according to it. So these are the brands which have S-shaped cross sections. And next will be your offset or rectangular off center. So this is the difference which I wanted to tell. In the first thing, it was like sharp rectangular. So this is a rectangular off center. So now what they have done is, the surfaces of the file, all the surfaces of the file will not contact the root canal. Okay, so it will be varying. So it is offset, that is, it is off center. So your file will not contact the walls in all the regions. Okay, your S file or your triangular file, at some point it is going to contact the walls. But this one, it will not contact the walls in all the places. It will selectively prepare, it will have a different shape. So it will not, all the surfaces will not come in contact with the root canal. So because of which, this space, the space is going to be utilized for your debris removal. Okay, so this is going to remove more debris, because it is going to move like a snake. Okay, so literally it will not prepare the canal much. It will just move through the canal. It will not form a much of debris. The debris production itself is reduced to a large extent. At the same time, there is a space through which the debris can exit towards the coronal region. So thereby, this will be the best one, so that the debris extrusion is going to be very minimum, and the patient post obturation pain is going to reduce a lot. So these, what type of files have these cross sections? Like, one will be your EDM files. Okay, if you can see, it is a modified offset triangle. And your high flex EDM, high flex CM, and your wave one gold pro taper next, all the higher end files comes under this list. If you can see, all the higher end files with from all the brands will come here. Okay, so this you can understand that, yes, I told you that when I'm going to pay a lot, I'm going to get a good file is actually true. Okay, so when you're going to, they haven't set the prices simply. They have set the prices according to the quality. So when you're going to go for higher end files in any brand, may it be Dentsply or your Cybron and or Colteen, it is going to be the best cross section you're going to get. Unfortunately, that is the truth which we can never avoid. So whenever you're going to have a off center of triangular, it is also necessary that it is not going to prepare the canals. Okay, not much of preparation will be done, so no debris will be produced, no pushing of the debris, and there also will be spaces. But one important thing is, when you're not going to prepare the canals, when you're not going to remove a layer of dentin around, sometimes when you don't have a proper irrigation systems, like you don't have a proper activators to activate your irrigant, when you don't use a proper sealer which can seal properly, your treatment might fail even though you're using a higher end files, because when this file is not going to prepare, it is not going to remove the efficalis manually. It is not going to remove the bacteria into the dentinal tubule manually. So you need to use a proper irrigation activation system to remove those bacterias. Okay, this can keep the preparation minimum, but at the same time, only when it is combined with the proper activator system and proper obturation system, you're going to get the 100% outcome. So only with the file, you cannot get the 100% outcome. So with these type of files, which is having minimum preparation, starting with your even your reciproc, even your reciproc is not going to prepare that much. So it is going to be a single file system. So when you're going to go in for a file system, which is going to prepare your canal very minimum, those type of file system should always be combined with a proper activator system, your irrigant activation system, and also a proper obturation sealer like a MTA sealer or a bioceramic sealer, which can penetrate deep into your dentinal tubules and provide the seal. So only if you're going to use it in a combo, you're going to get it 100%. Only with the files, you cannot give the 100% treatment to the patient. So these are the general brands which are available in rectangular or off-center endodontic files. And then coming to your rotating and reciprocating motion. So there are two file systems in general that are available in the market. One will be your rotating and another one will be your reciprocating. So rotating is nothing but your file is just going to rotate in an anti-clockwise or a clockwise direction. Okay, so nothing much to think about. When it comes to reciprocating, what it does, it goes in one direction, clockwise direction, up to a 90 degree, and then it comes back again in the anti-clockwise direction to a 30 degree, and again goes back in clockwise direction. So to and fro, it is going to come and go. So this will be your reciprocating action. So one of the reasons why reciprocating action was found. So why this நீங்க வந்துட்டு like if you're going to give if you're going to put a screw on a wall, if it is going to rotate, it will go straight into the wall without it will not decide the pathway. So just if you're going to keep on screwing, it will just go on any pathway, no matter like however you direct it, whichever pathway it is forced into, it will go. Okay, but at the same when you're going to give it a reciprocating action, it will follow a pathway given to it already. So that is the reason why reciprocating files were found, because they wanted to center the file. Okay, because the file sometimes they form ledge and go towards some other direction rather than the canal's same direction when done in rotating motion. So they wanted to keep the file in the center through the canal. No matter what, how much ever you push it, it will go in the pathway where the canal is going. It will not go anywhere else. So that way this reciprocating motion was found, so that the centering ability of the file can be increased. Now the problem is, whenever you're going to have a continuous rotation, your apical debris extrusion is less. Okay, so because whenever it is going to rotate, the debris will actually move up like a your conveyor belt. It will move up towards the coronal region. So your post-obturative pain and lower incident of flare-ups can be seen in continuous rotation cases. When it comes to your reciprocating files, what happens is when there is reciprocating action, your debris is actually pushed into the canal. Okay, rather than your debris pushing towards the coronal, it is pushed inside the apical region, because of which the pain when you're going to use a reciprocating files is more. So that's why you need to weigh in, do you need a centering ability or do you need debris extrusion? So you need to have a balance between both. So when you're going to require centering ability, so I want centering ability, I don't want my file to go anywhere else, I want it to follow the canal path, so I want to be safe, I don't want to form any ledges, then you can go for reciprocating files. But you need to be careful, you need to have a proper irrigation system, you need to have EDTA liquid final irrigations, and you cannot go beyond the apex, and all these careful like repeated irrigations in between the files. So all these things you can follow when you're going to go for reciprocating files, because your reciprocating files are going to extrude more debris towards the apical region. So you need to take the precautions. You need to weigh in which type of file you need, which benefit you need to take from that file. And next will be your role of flexibility. So now we have seen that there are four types of general cross sections and how they influence the debris extrusion. Now you know, like you need to select a S shape cross section or a off center rectangle or a off center cross section files. But you need to weigh in the cutting efficiency also, as it is going to be like starting from your rectangle, triangle, S, and your off center, the cutting efficiency keeps on reducing. The debris also reduces, the cutting efficiency also reduces. So you need to weigh in, do you require more cutting efficiency or do you reduce the debris? So you need to weigh in depending on the cases. Like in calcified cases you need more cutting efficiency, so those type of cases you need to modify your file systems what you're using. And other than that, you need to check for these three factors as well. Your file flexibility. So whenever you're going to have a flexible file, it is going to stay at the center. So whenever this file is going to stay at the center of the canal, it is not going to prepare much of the walls. A little bit of wall preparation only will happen, because of which the debris production is going to reduce a lot. So you need to have a centering ability maximum file. So whenever this canal, right? So this is a canal. So when your file is going to prepare only the canal, only a little bit of debris is going to be produced. So your file should stay at the center. So only when your file is flexible, it will follow the pathway of the canal and it will stay at the canal and it will prepare much less, so that the debris production will also be less and your apical extrusion will also be less. When it comes to your control memory versus your shape memory, so when it comes to your control memory, so whenever the previous slide I told you flexibility, so your control memory files are going to be more flexible, because when you're going to bend it, it is going to stay in the same temperature or same shape. So when you're going to reheat it, it will come back to its original shape, but it is going to stay in the same shape like how the canal is. So the centering ability of this control memory files is going to be maximum. So when the centering ability is more, then your debris production is less and your post-obturation pain will also reduce. So if you want to reduce debris, your preferable files should be control memory files. So your control memory files will be from your blue, dark brown or your gray color files come under control memory files, while your silver and your shining silver and shining gold, they come under shape memory files. So control memory files are more preferable if you want to reduce the debris. And the next will be your heat treatment. So more heat treatment, more will be your memory, your memory changes as well. So when you're going to heat treat it less, it will be in golden color, it will have shape memory, so it will show more debris. Okay. As you're going to increase the temperature, the color of the file and the nature of the file is going to change. So when you're going to heat treat, a conventional file will be in silver in color. Okay. So when you're going to heat treat it, your silver color files are not heat treated, completely not heat treated. Nickel titanium files are silver colored, shining silver. When you're going to heat treat it to around 250 to 300 degrees Celsius, it is going to become golden color. So this gold color files are also shape memory files. They are also less flexible, but the cutting efficiency is high. But what happens? More debris, but it is not flexible. So because of which the debris is pushed inside the canal. And next, when you're going to heat treat it, it will turn into blue color, which is actually a control memory file, more flexible. So your debris extrusion is much more reduced when it goes to blue. And further, when you're going to heat treat this blue as well, it is going to change into a dark brown or a dull gold color or a brown color file or a gray color file like your high flex EDM. So this gray color file and this brown color file are significantly going to reduce debris extrusion, because they are going to stay at the center of the canal. The centering ability of those files are more, because of which the debris production, that is, they will not prepare much of the walls, because of which the debris is much less. And also the design of the file will also play an important role in pushing the debris towards the coronal region. So the debris extrusion itself is reduced in higher treated files, high heat treated files. So more the temperature, more lesser the debris production and debris extrusion. And then your core sizes. So whenever the core, this red color, so whatever might be the cross section, whatever might be the shape of the file, this core size also plays an important role. So this core size is nothing but the size of the file, ES1, ES2. So these core sizes are vary based on your sizes of the file and also the shape of the file, cross section of the file. So this core size is, when it is large, it will push the debris towards the apical region. When it is small, it will push the debris towards the coronal region, because more space will be there in between the canal walls and the file. So this also plays an important role. So whenever you're going to go for, immediately when you're going to put a larger size file in the canal, so you need to have a series. You need to first start with a snug fit file, initial apical file, then progressively go. Otherwise, you might end up pushing the debris. So if you're going to put a larger size file into the canal, then you're going to push the debris into the apical region. So you need to follow the series, like you need to follow the series of files. You need to increase gradually. The file sizes should be increased gradually. You need not put directly higher size file on the canal, then it will push the debris. And then your design. So whenever you're going to have an off-center design, more the space in between the canal wall and the file, more will be the debris movement towards the coronal region. So whenever it is going to be completely radial, so when the file is going to contact the entire canal surface, your debris will be packed towards the apical region. Okay, so this is the general considerations. So when it comes to what you need to consider first, so I have told you about many things. It is very confusing. See, I told you reciprocity shape, it will produce less debris, but at the same time, reciprocating action will produce more debris. So you will be confused what to choose first, how to order it. So this is the order which I'm going to give you. So when you're going to choose the file, first you need to give importance to the kinematics. Okay, kinematics is nothing but rotating or reciprocating. So that will play a major role. So first select kinematics, then go for cross section. So I told you about the four cross sections in the order of how much debris is produced. Then you go for core size, then flexibility, and then the metallurgy. Metallurgy is nothing but the heat treatment. Okay, so flexibility of the files and metallurgy comes the last. So with these factors, considering all these factors, you need to select the file system so that you can have minimum debris production, more pushing of debris towards the coronal region, and then more centering ability. So the file should have more centering ability. It should stay on the canal. It should not go anywhere else towards one side or towards another side. It should not move. It should stay on the center. These all factors, and it should be flexible. It should follow the canal anatomy. So these are the things which will influence our post-obturation pain. So you need to select the file system as well, so that debris production is reduced to an extent, so that the patient will not have any post-obturation pain. So any doubts, you can shoot in the doubts. We can have a quick discussion. Any doubts, doctors? Any doubts? Is it audible, doctors? Is it audible? Actually, I have pain while BMP is will be because of two reasons, doctor. One will be like LA did not work, or even if the LA worked somewhere else, it did not work on the tooth. So in hot tooth cases, you will have pain in during BMP. And how you can manage is, like, one thing, check whether your LA has worked properly. Okay. The second thing, if your LA has worked in other regions, you can you can give intrapulpal injection and then do BMP, so that will reduce the pain. And even after giving intrapulpal, even after extirpating the pulp, if the patient is having pain doing during biomechanical preparation, you need to check whether the working length is correct, and you need to have other checkings like working length is correct, or if any ledge formation is there, you need to check whether that. And if the bleeding is there, so, along with pain, if bleeding is there, there might be two reasons. One will be your ledge formation, another one will be your pulp tissue remnants. So, if after doing a BMP, like if you continue doing BMP, if the bleeding keeps on reducing, then it is because of pulp tissue. When you're going to do instrumentation and the bleeding keeps on increasing, then it might be because of ledge formation. So these are the reasons which can be because of pain while BMP. And how many times a file can be used. Uh, my recommendation would be to use it for 10 to 20, 15 canals. Okay. If it is a higher end file like gray, or a more heat treated file, more flexible one, you can use it for 20 canals. Manufacturers, they will tell you 30 canals, 40 canals and all. I usually don't recommend it. I have not broken any file at all. I have broken only two files in my entire practice. That is because, not because of my technique, that is because of the precautions which I take. So the major precaution which I take is to discard the file after 15 to 20 canals. So whenever I'm going to do a difficult case, a calcified case, or a curved canal, I make sure I take up new files. And that is the protocol which I have been following, and I also recommend the same. So no matter what type of files you're using, like may it be a neo endo, oricam one, or a high flex EDM for coltine, uh, my general recommendation would be for 10 canals. Okay, so may it be whatever files. Yes, you can use EDM files for more number of cases. So series of irrigation protocol, you need to start, it depends on the tooth nature. So if it is a non-vital tooth with pus discharge, you need to start with chlorhexidine first. So you need to give a chlorhexidine wash, then do BMP with EDTA, and finally after finishing BMP, you can go in for a EDTA wash and placement of intracanal medicament. And then while obturating, you can go in for chlorhexidine wash again and obturate. When it comes to vital tooth or pulpitis case, you can start with sodium hypo. So first, as soon as you do access cavity preparation, you can start first with sodium hypo. So you need to take precautions when you're going to use a sodium hypo. You need to isolate the tooth, and don't push the irrigant into the into the tooth. You need to be very gentle so that you don't do any apical extrusion of the irrigant. And after using sodium hypo, you follow it up with saline, remove all the pulp tissue. Then you do BMP with EDTA gel. After doing all the biomechanical preparations, in between each file, you need to do saline irrigation. And then finally, you can have a wash with EDTA, a liquid EDTA, and wash it with saline. And just before obturation, you can do a chlorhexidine wash, and with saline, follow it up with saline or deionized water, and then go in for obturation. I literally don't use hydrogen peroxide, doctor. So I don't use hydrogen peroxide, and I don't think that it is necessary. So in general, I have been following this protocol, and this protocol is actually a universal standard. If you go and look into many studies, it is a protocol followed by American Dental Association. So hydrogen peroxide is not necessary. So we have three components in our canal. So we need to do three functions in our canal when we are doing BMP. So one will be to remove the pulp. So that is done by your sodium hypo, and a little bit of antibacterial agent is also, like antibacterial activity is also done by sodium hypo, but it is not covering gram negative bacteria, and many a little bit of bacteria are not covered by sodium hypo, but it does have antibacterial action. And the next action would be to remove the smear layer. That is done by your EDTA. And final chlorhexidine, it is going to act on your E. fecalis and all the tough bacteria. It will disinfect those. And in case if you're going to obturate it on the, like, if you have a weeping canal or something, you can go in for intracanal medicaments like calcium hydroxide or a triple antibiotic paste. So this is the protocol which I'm following. So I don't use hydrogen peroxide. No, doctor. Occlusal reduction is not necessary. If you're going to do proper working length is done and BMP, you keep these things in mind. No debris extrusion, copious irrigation activation, adding liquid EDTA to your regimen. All these things, if you're going to keep in mind, you need not do occlusal reduction. I am not doing occlusal reduction. You can ask my junior doctors also if you want. I am not doing occlusal reduction for any of my RCT cases. There won't be any pain. The pain will be there for like 1 or 2 days. The patient might have mild pain, but it will regress completely after 1 or 2 days. During access opening for the molars, sometimes I prefer doing like occlusal reduction, provided that I am going to restore the tooth with crown. Okay, so sometimes I select to restore the tooth with onlay or inlay. In those type of cases, I do not do like occlusal reduction. In cases, yes, I'm going to give a crown only. In those cases, in molars, I prefer doing access opening, like occlusal reduction, to ease my access opening. And for the preparation, posterior tooth, when you're going to use rotary, it is a little bit for difficult for accessibility. So in those cases it will be easy if you're doing occlusal reduction, but you should keep in mind you don't reduce more than how much it is necessary for the crown. You can use it for about 1 minute, doctor. 30 seconds to 1 minute would be ideally I can use, but it is recommended in some books that you can use it up to 2 minutes. But what I do is I keep sodium hypo only for 30 seconds to 1 minute and then I wash it off. Warm hypo is much faster in action. It is much faster in action according to the book. Is it helpful? I don't think so. It is not going to increase the efficiency of sodium hypo. It will just fasten your sodium hypo's action so that you can keep it in the canal for much lesser time when you're going to use warm hypo. That is the only thing. And you need to modify the percentage of hypo. So that is what I concentrate on. So when I'm going to use sodium hypo for open apex case or any abscess case or root resorption case, I use less percentage of sodium hypo, like 2.5 percentage, or I dilute sodium hypo. When I'm going to use it for vital case, vital to like therapeutic, like for bridge case, if you're doing intentional RCT or acute pulpitis case. So those type of cases, I usually use 5.25%. So I modify the percentage of sodium hypo. I usually don't heat it. It is an extra step for me. So I keep it simple. My practice, I keep it simple because I do multiple RCTs. I don't have much time. So that's why I keep it simple. So I modify the percentage according to the case, but I don't heat it. I don't think so. It has much of use. And yes, you need to sterilize the file, especially your control memory files. So when you're going to autoclave it, not only you're going to clean the files, it is also going to, not only it is going to sterilize the file, it is also going to revive the file to its original shape. Okay, so your control memory files, they tend to stay in the same shape when it is not heat treated. So when you have used a file in a patient, it is going to curve like this. Then again, when you're going to use it in some other patient, in some other canal, which is like this, then you will have a file breakage. So in between the use, you should always do autoclave the files. But the another one problem is that more you autoclave, more cyclic fatigue will be there. So I don't recommend more than 4 to 5 cycles of autoclaving a file, because after 4 to 5 cycles of autoclaving, your files have the tendency to break. So that is also a precaution you need to take. So if after each use, you need to autoclave to like to revive the actual shape of the file. But at the same time, you should not exceed more than 4 to 5 times. So it is coming to the same number, like 10 to 15 canals. So again, it is like 10 to 15 canals is the lifetime of a file. So that should be there. Glass bead sterilizer, it is useful, doctor, but when you're going to heat treat at 120 degrees Celsius or 130 degrees Celsius, it is going to come back to its original like shape. So that is very important. That heat treatment is very important to bring back the file to the original um, shape. You can do it in other way also. You can directly heat treat it. Like you can directly, if you have a control memory file, try to bend it and heat it with fire. It will come back to its original position. You can do that also. Diluted hypo. Doctor, I have like a 3% sodium hypo and 5.25% sodium hypo. I have both in my clinic. So what I do, I use 3% in cases where pulp extirpation is not required, where there is no pulp, like abscess cases, pulp necrosed cases, and open apex cases, root resorption cases. In those type of cases, I usually use 3% sodium hypo. So I don't use it for longer time. I don't use large quantity. I use only zero point 0.5 ml of sodium hypo. I inject it on the pulp chamber and I just activate it, and then I wash it off within 30 to 1 minute, 30 seconds to 1 minute. But when it comes to like cases where I need sodium hypo, like it's a pulpitis case, vital pulp is there, at that time I use 5.25% sodium hypo, a little bit more, like 1 ml to 2 ml. I inject it into the canals a little bit, but I don't force it inside the canal. I use rubber dam, and then I leave it there for 30 seconds to 1 minute so that it can act. There will be lots of bubbles, and then you can remove it off with saline wash. So this is the protocol which I'm following, because at some cases it is not required. The sodium hypo, only a disinfection. It can be used only as a disinfection, or it can be used as a devitalizer. So you need to choose where you need to do use it as a devitalizer. Only then you can use 5.25% per canal. That's what doc. So you can like take about 1 to 2 ml depending on how many canals you are having. Like if I'm doing a molar case, like 4 canal case, I take up 2 ml. For each canal, you can inject a little bit of 0.25 to 5 ml is enough, because your canal is going to be very small, literally. So only little bit is enough, and leave it there for some time. And then when you're going to do a saline wash, and then you're going to do BMP, all your pulp is going to get extirpated automatically. Then in in your non-vital cases, you can place a little bit of 0.5 ml in the pulp chamber and activator. So activator is very important. So you can use endo activators to activate the sodium hypo. It will get activated inside the canals. So it will have much more action. So when you're going to combine activator with irrigant, little amount of irrigant is enough. So when you're going to activate a irrigant, even a little amount of irrigant, when you're going to inject and when you're going to activate it, it will activate properly and it is going to go inside all the retinal tubules. You need not use huge amounts of irrigant in such cases. But when you're going to not use a activator, at that time, you need to take up to 1 to 2 ml, so that the entire file, entire canal gets, it is gets, the irrigant gets inside the entire canal. There is a protocol which is given by Grossman, who actually, for how to know that a tooth do not need a crown. So it is a protocol given by Grossman, who is actually, it is a very old person, right? He wrote his book about 100 years ago. He himself has told that whenever a tooth which you're going to take in for RCT, if the tooth is having all the four walls, sound tooth structure, when the tooth is having all four walls, uh, or three walls are which are very sound, like 1 to 2 mm breadth walls are there, then you go in for restoration. When the tooth is having two sound walls, okay, two sound walls, 2 to 3 sound walls are there, then you go in for crown. And when the tooth is having only one or two sound walls, you go in for post. And when the tooth is not having any walls, then you go for metal post. So this is the indication given by Grossman. So whenever the tooth which you're going to take in for RCT, after doing access cavity preparation, that is, first step would be to remove the caries and then the access cavity preparation. So after doing that, if the walls are sound, So if you have three walls which have sound tooth structure, you can always go in for inlay, metal inlay or ceramic inlay. And if you have sometimes you can even go for onlay. So depending on the sound tooth structure, so if the tooth structure is sound, you can always go in for conservative procedures, restorations. Even you can go in for composite restoration. If all the four walls are sound tooth structure, you can go for composite restoration. But one problem is that the composite restoration should be the composite material should be of high quality. So you should use a very good bulk fill material, like your Impress or your Tetric, yeah, Evoceram, or your extra fill, bulk fill, those type of materials which can withstand the occlusal forces. So you need to use higher end composite in such cases. When you're not going to give crown, you're going to give only the restoration. My recommendation should be to give a good composite material. So now coming to why there is a general myth, like when you're not going to give the crown, the tooth is going to crumble. So yes, the tooth will crumble only under two conditions. When you're going to uh, not give a crown on weakened tooth structure. Okay. So already if there is a weakened tooth structure, there is no tooth structure. At that time, when you're going to do conservative procedure like restoration, inlay, onlay, if you're going to do it, will crumble. But when you're going to do these procedures on sound tooth structure, you're actually, in fact, you're going to strengthen the tooth, because if you compare the strength of ceramic or strength of your ceramic or your strength of the tooth, your tooth is going to have more strength. Okay, the sound tooth structure will have more strength. So removing sound tooth structure and giving a ceramic crown is actually going to reduce the strength of the tooth. So it is better, if there is sound tooth structure, you need to preserve it, and preserving it, and the balanced tooth structure needs to be restored. So you can plan accordingly, overlay, onlay, inlay, anything you can do. How to remove the debris from a file before entering the next canal. So doctor, there is one sponge, right? A file cleaner sponge. It is available even in dental cart. I have been using it. So when you're going to place the file on it, it will self clean it. Or you can use a cotton, but cotton, that fibers, they get stuck in the files sometimes. So the better would be the sponge. I don't know what is the name. So it is like a normal sponge, like how you wipe the blackboard and all, right? That normal sponge only you can have it in your chair side. You can just place the file on it, prick the file on it. It will self clean and come out. It is a very easy thing to remove the debris from the files before using it in the next canal. Any other? H files, doctor, H files cross section is very different. Actually, the cutting efficiency of H file is high, but at the same time, the flute spaces are very more in H files. So when you're going to use it on multiple patients, the fracture of H files are going to increase. So it is better you use it in very less patients. You can use it for three patients maximum, and the efficiency of the H file to reduce the GP also will reduce as you're going on keeping on using the H file. So now H files, it is used only for GP removal. Okay, GP removal you can do it with rotary also. I usually use a high flex remover. Now H files I don't use in general for GP removal, but even if I'm using this high flex remover also, the apical one third, right? The 1 to 2 mm of the apical region, we cannot use this high flex remover files on that region. On that region alone, I use H files to remove the GP. So that time I make sure that I take H files, fresh H files every time. Okay. So I discard the file after each use, but you can use it for 2 to 3 times, not more than that, because the efficiency it decreases as you keep on using H file. I have done a H file breakage in a case while retrieving the file, retrieving the GP, like while removing the GP, I have broken a H file. So H files, they tend to break a lot. So it is better you discard it after each use. Any other doubts, doctor? Doctors, I have covered everything, I guess. Yes, yes, doctors, I have covered all the questions. So thank you, doctors. Thank you so much for giving me time so that I can have a good communication. So we will come back. I am having a conversation with orthodontist. So I have asked them to take a webinar next month. So I will come up with the topic soon. So next month on Jan, the new year, we will have an orthodontic topic because I myself don't have a clear picture on ortho. So I keep on asking my orthodontist friends to take webinars so that I can learn. So let's wait for them to confirm, and I will send you in the group. So stay tuned, stay in the group so that I can keep on taking. I will take, and I will ask my friends to take, so we can have very good sessions. Thank you, doctors. Thank you. Thank you for your time.